Hi, my name is Pamela Zambrano Pincay and I am going to talk about nephrotic syndrome. Definition. Nephrotic syndrome is a non-specific kidney disorder characterized by a number of diseases like proteinuria, hypoalbuminemia, edema. It is characterized by an increase in permeability of the capillary walls of the glomerulus, leading to the presence of high levels of protein passing from the blood into the urine. Minimal change disease. Minimal change disease, or MCD, is the most common cause of nephrotic syndrome in children. 70 to 90% of nephrotic syndrome cases in children and 10 to 15% in adults are due to MCD. MCD is typically idiopathic but can rarely be associated with Hodgkin disease or non-steroidal anti-inflammatory drugs. MCD presents clinically with the abrupt onset of proteinuria in the nephrotic range, acellular urine, and edema. In children, the proteinuria is primarily albumin and is called selective proteinuria. Diagnosis in children is usually presumptive, and a renal biopsy is only done in non-responders to steroid therapy. Treatment is with prednisone 60 mg. Adults often require longer courses of therapy than children. Histologic findings. The essential of diagnosis is that nephrotic range proteinuria. Kidney biopsy shows no change on light microscopy, and characteristic food process effacement on electron microscope. Glomeruli show no change on light microscope or immunofluorescence, as I said. On electron microscope, there is a characteristic effacement of podocyte food process. A subgroup of patients also shows mesangial cell proliferation. Such patients have more hematuria and hypertension and poor response to standard corticosteroid treatment. Focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis, or FSGS, accounts for 10 to 15% of nephrotic syndrome in children, and in adults, it represents 1/3 of non-diabetes associated nephrotic syndrome. It is even more common in African American adults, in whom it is the etiology of more than 15% of cases of nephrotic syndrome. FSGS can either be primary and idiopathic or secondary to either a familial or systemic process. Focal segmental glomerulosclerosis, primary focal segmental glomerulosclerosis, secondary focal segmental glomerulosclerosis is associated to viruses like HIV, hepatitis B, parvovirus, hypertensive nephropathy, reflux nephropathy, cholesterol emboli, drugs like heroin, analgesics, famidronate, oligomeganephronia, renal dysgenesis, Alport syndrome, sickle cell disease, lymphoma, radiation nephritis, familial podocytopathies, etc. Membranous glomerulonephritis. Membranous glomerulonephritis (MGN) accounts for 25 to 30% of nephrotic syndrome in adults and is the most common cause of nephrotic syndrome in elderly people. Most cases of MGN are idiopathic, but 20 to 30% of cases are associated with malignancies, solid tumors of the breast, lung, colon, infections like hepatitis B, schistosomiasis, malaria, or rheumatologic diseases, systemic lupus, rheumatoid arthritis. 80% of patients present with nephrotic syndrome with non-selecting proteinuria, and 50% of people present with microscope hematuria. Because of the thrombogenic conditions associated with nephrotic syndrome, thrombotic events can be a feature of many glomerular diseases. Symptoms and signs. Essential of diagnosis: nephrotic range proteinuria associated with coagulopathy, renal vein thrombosis if nephrotic syndrome present, spike and dome, pattern of kidney biopsies from subepithelial deposits. Secondary causes notably include hepatitis B virus and carcinoma. Patients with membranous nephropathy and nephrotic syndrome have a higher risk of hypercoagulable states than those who with nephrosis from other etiologies. There is a particular predisposition to renal vein thrombosis in these patients. There may be symptoms or signs of an underlying infection or neoplasm, especially lung, stomach, breast, and colon cancer, in secondary membranous nephropathy. Differential diagnosis: other edema states, cirrhosis, primary renal diseases, glomerulonephritis, membranoproliferative glomerulonephritis, carcinoma, infections, malignant hypertension, polyarteritis nodosa, serum sickness, toxemia of pregnancy. Laboratory test. Urinalysis reveals proteinuria. The presence of hematuria, cellular cast, and pyuria is suggestive of nephrotic syndrome. Oval fat bodies are also found in the urine in patients with nephrotic syndrome. 24 hours unit protein excretion is higher than 30.5 grams in 24 hours. Abnormalities of blood chemistry include serum albumin lower than 3 grams per deciliter, decreased total protein, elevated serum cholesterol, glucose, azotemia. Additional tests in patients with nephrotic syndromes, depending on the history and physical examination, are NN, serum and urine immunoelectrophoresis,